case-based discussion. And I request Dr. Santhanam to chair the session and Dr. Mohan to co-chair the session. To deliver this lecture, we have one of the most eminent nephrologists of Chennai, Dr. M. Vijayakumar. I request the co-chairperson to welcome and greet the speaker with a bouquet.
Dr. Vijayakumar to come on the dais, please.
I request Dr. Santhanam to garland the speaker as a mark of respect. I now request Dr. Santhanam to briefly introduce the topic and the speaker.
Good evening. Now on the dais our guest speaker, Dr. R. Vijayakumar, had his undergraduate and MD both from GPER Pondicherry. He won the gold medal of Madras University for the best MD candidate. He got his DM degree in nephrology from Madras Medical College and continued as assistant professor with HOD in nephrology in Stanley for 12 years. In Stanley, he has re-established an active kidney transplant program and has done around 500 live renal transplants there. He also started DM nephrology course. He made Stanley proud by making it the biggest transplant center among all state government hospitals in India. He also served as secretary of the Southern Chapter of Nephrology. He has publications in journals and his work on fungal infections is quoted in Peter Morris' book on transplant. So he has got so many credentials to the journals and also book. With this, I welcome Professor Dr. R. Vijayakumar to deliver his lecture. Thank you, sir.
Thank you, Dr. Santhanam, for the kind words. Thank you, Dr. Mohan, the organizers who called me once again. So I thought, okay, they are not bored with the last year's lecture. So thank you for the audience. I find a large audience on a Saturday evening. Normally I would expect the audience near my house because I am situated very near Pothis, Kumaran and Pandi Bazaar and whatnot. So very nice to see a large audience here rather than near my house. With this I will go through the lecture. Basically I made it into, because last year we had told about some didactic lecture. So I thought this year we'll move on to some case-based approach. So to see some, actually all are real cases except that I have had the liberty of tweaking some of the lab values for our purpose. So why diabetic nephropathy is so important? Because dialysis consumes a lot of money and it's a drag on the exchequer and the patient's money. So 50% of dialysis patients in our dialysis center, where we do about 2,800 dialysis per month, we have about 45% are diabetic nephropathies. That means close to 1,300, 300 dialysis done on diabetic patients. So we are reaching the stage where we will be reaching 50% very shortly. So dialysis is started for diabetic nephropathy and these patients constitute the majority. Even though they live relatively less compared to the non-diabetic population, the number of patients of diabetes on dialysis is increasing. That shows the total burden. And this is not to speak of the patients whom we lose or not able to dialyze because of cardiovascular complications which occur before they develop diabetic nephropathy. If you add that, the burden is on the tertiary care system by the diabetes is very clear. So we'll just go through a patient whom I saw very many years back, 12 years back or 15 years. 58-year-old Jane, a diabetic of 20 years duration. He had a one value of creatinine about 1.6 milligram. He was on metformin and chlorpropamide at that time. He had been admitted in a hospital with diarrhea, severe acidosis. Creatinine was 6 milligram. He was very much dehydrated. Blood sugar was very low, 38 milligram, and your dextrose was there. He was relatively unconscious, drowsy. He had severe oliguria. They had given diuretic. Classics was administered because the patient had very severe oliguria. So we saw him. We stopped the oral hypoglycemics and diuretics also. Because of acidosis, we gave bicarbonate. Generally preferred to give isotonic bicarbonate. If you dilute the normal bicarbonate with 500 ml dextrose, it becomes isotonic. So we generally prefer to give hypertonic bicarbonate. Ideally, you have to give it central venous route. So it is preferable to give in the dextrose or solution. And we gave normal saline to hydrate him. Gradually his output improved and creatinine came down to 3.5. And hypoglycemia persisted for 1 week. So on inquiry we found, because he was taking the chlorpropamide for nearly so many years, he continued on chlorpropamide even while he was in the hospital. We didn't know. But he had the tablet. He said, every morning I used to taking. I was taking even under observation. So chlorpropamide has got such a long action that it persisted in the presence of renal failure. And many a time, sometimes even today, we find chlorpropamide or longer acting sulphonylureas bring forward the renal aspect. Otherwise, the renal failure is not noticed. Till they develop an hypoglycemia, we check patient has renal failure. So what is the lesson? Don't use metformin beyond 2 milligram. It would have worsened the acidosis in him. Some would say 1.4, but present indication would say 2 milligram. And avoid long acting drugs, especially in nephropathy, you avoid long acting drugs. And whenever patients get admitted with the long acting drugs and renal failure, you discontinue the drugs. And any patient with renal failure or even borderline creatinine, the creatinuria check is a must. We see diabetic patients with lot of sugars values they will have, but urea creatinine may be lacking. So think of eye, kidney, cardiovascular system, peripheral vessels, everything also. So regular urea creatinine check, I believe it's a must. Otherwise you will miss a renal failure. At least you won't know when he develops an acute renal failure, he had a normal renal function. 1.6 milligram looks near normal. The value normal given is something like 1.4 in Harrison. So 1.6 really innocuous. It is not so. That means the glomerular filtration rate has already fallen by 50 to 60%. That means the reserve is hardly 40%, 40 to 50%. So 1.6 milligram creatinine, as a matter, even the higher value of 1.4 milligram signifies the patient has lost 50% of his glomerular filtration rate. So one has to be creatinine. And any borderline creatinine value like 1.3, 1.4, you have to be very careful, especially in a thin, lean individual. We expect the creatinine depends on the muscle mass, which is the kidney function. A person of 40 kg, supposing he has 1.2 milligram, it has to be little suspicious. So ideal is to do the MDRD equation and calculate the estimated GFR. So these are the anti-diabetic options for patients with chronic kidney disease. So number of meetings they ask me what are the ones we should give. So we are divided into more than 60, that is about 2 milligram of creatinine will be here, 30 to 60, less than 30 and less than 15, hemodialysis and others. So if you see metformin, we have to stop when the creatinine reaches 2 milligram. However, we can give glycoside. It is quite safe to give. You have to reduce the dose in the dialysis, but you can give even patients on dialysis. Similarly, glimepiride can be given. Others are not given. The other one you can give is repaclanide. We can give all through. Acarbose, we have to stop when the GFR or creatinine comes to around 3 milligram. Glitazones theoretically can be given, but we don't give because their potential for sodium retention. So the edematous patients, these people are already prone to pulmonary edema, so they can retain fluid, so pulmonary edema can be precipitated, so we don't give. Some of the gliptins can be given, dose reduction even on dialysis you can go. Of course, insulin can be given in all patients. So it is easy to remember, You can avoid metformin beyond 2 milligram. You can use glycoside, glimepiride or epaglenide up to dialysis. You can use gliptins. Some require dose modification. All of them require dose reduction about 50%. Till dialysis you can use, and insulin of course we can use. What about the use of diuretics? The patient was given diuretic on admission. So no point in giving a dehydrated patient a diuretic. Diuretic is not going to improve the kidney. They are symptomatic treatment to get the patient out from pulmonary edema or a fluid overload. So they are not going to kidney. They are not going to improve the kidney. So prescribe only if patient has edema or heart failure evidence is there. And do not prescribe till the patient becomes dry, no edema. That looks cosmetically nice, but it is not advisable. Mild edema means patient is reasonably hydrated, nothing to worry. It is not only acceptable but also desirable. It is better to leave the patient with mild edema. That means the extracellular fluid is adequately filled. If you are going to get rid of edema, you don't know, it's difficult to assess the mild volume depletion, the creatinine can go up. So it is better to have a mild edema than have no edema at all. And we tend to avoid IV diuretics better because unless they require, because we have to preserve these veins. These veins are very important for renal failure patients. These are the veins which are going to use for their future fistula creation. So these veins are very, very critical. They are the lifeline for these patients. So do not unnecessarily give IV. Most of the oral drugs are sufficient unless they are in an emergency situation. And diuretic dose need not be stagnant. You give 3 tablets or 2 tablets because patients are resistant. Reduce the tablets or stop. So dynamically change depending on the patient condition. Do not use the as minimum diuretics as possible. And remember, when you add diuretics to ACE inhibitors or angiotensin receptor blockers, severe hypotension is possible. So you have to be careful, add a lower dose. Make sure they are not dehydrated. If suppose the patient is dehydrated, when a patient is already on ACE inhibitors or ARB, do not use diuretics. They are dehydrated. And second thing, unlike heart failure, in chronic kidney disease, the restriction has to be both salt and liquid. Both have to be restricted. Liquid restriction alone may not help because if you take salt, definitely the need for liquid will be high. Salty food 5 gram to 10 gram if you take more salt, that much of water is required. You will feel thirsty. So restriction has to be both salt. Unless salt is restricted, very difficult to restrict the fluid intake. Then the patient came for follow-up. He was coming. There was a stable creatinine of 3.5. Hemoglobin was 8 grams. So he was being seen by the nearby doctor. So immediately prescribed erythropoietin 4,000 units twice a week. He was started. So what about EPO? Because now EPO is available and it has come into the general physician's realm. So it should be used with caution. EPO is no use. One thing is you have to be certain that it is useful, and second thing you have to be certain it is not harmful. I will tell you. You have to check the iron stores before you prescribe EPO. Many of the patients of renal failure have iron deficiency. So the iron deficiency has to be looked for and corrected before we give erythropoietin. If iron stores are low, you must also think of other causes of iron deficiency. It may be a duodenal ulcer or even be a carcinoma. Recently we have detected 2 patients of carcinoma in elderly individuals. One of them was a diabetic who had anemia and renal failure as a presentation. And you have to ensure folic acid and B12 are either checked or at least given because the cost is low before the giving erythropoietin. Especially vegetarians have very poor B12 levels. How do you check the iron stores? We can do by the 3 tests. One is iron levels, another is TIBC, that is total iron binding capacity, third is ferritin. These are the 3 tests you have to do to know the iron level. Previously we used to do the bone marrow. Now we no longer do the bone marrow. If you divide the serum iron by total iron binding capacity, you get what is called transferrin saturation. So 60 by let us say 120 means you get 50%, that means well saturated. 60 by 360 means it is 16%, that means it is transferrin saturation is 16, that means it is low. If patients require oral iron or IV iron, generally now what we use is iron sucrose preparation, which can be given maximum of 200 milligram per dose up to 1 gram as drip. Only if the transferrin saturation is less than 25. If it is more than that, no need to give. That means patient has got reasonably, I am not telling a perfect thing, but for practical purposes, transferrin saturation should be more than 25, means patient has got adequate iron stores. If it is less than 25 with anemia, that means patient does not have adequate iron stores, in which case we can give oral iron, which may or may not be absorbed. For in renal failure, we prefer to give IV iron sucrose maximum 1 gram, which can be divided into 200 milligram steps each time you can give. The other marker is the ferritin, which should be 200 if the hemoglobin is less than 10. The hemoglobin anemia is there, the ferritin level should be at least 200. Otherwise, patient will not have sufficient iron stores. Even if you give erythropoietin, it cannot be incorporated without the heme moiety which contains iron. So one has to ensure there is adequate iron stores before we give erythropoietin. Second thing is, remember, infections will reduce the effectiveness of iron. So a patient has got fever, other systemic infections, no point giving erythropoietin. We should start at 6,000 or 8,000 per week, that is either 3,000 twice or 4,000 twice. Lower dose are ineffective. If you start at a very low dose, because it's costly, 2,000 twice a week will itself cost quite a bit. So start with a slightly higher dose, then titrate down. Always check the affordability, because erythropoietin may have to be continued for a longer period. They are not going to improve their kidney function. That means they will require longer period. So if they are not prepared to spend so much, and if they prefer to spend the money on dialysis, better save the money. Giving few doses of erythropoietin and stopping will not help. So check the affordability of the patient before use. Sorry, it's not weekly. The monthly rise should be 1 gram hemoglobin. Monthly, even if you give high dose of erythropoietin, the rise will not be more than 1 gram. And we should maintain hemoglobin only around 11 grams. Do not go beyond. The amount of erythropoietin, to make it 12, supposing you use about 6,000 units, to make it 12 you require 9,000. To make it 13 you will require 13,000, 14,000, double the dose. More than 12 gram is proved to be harmful. It is definitely very harmful to the patient. Higher incidence of stroke, higher incidence of myocardial infarction has been proved. So keep the hemoglobin around 11. This is sufficient. You do not have to exceed 11. Maybe do not allow it to cross 12 at any cost. If it crosses, you stop the erythropoietin. For the further follow-up, the patient was coming. His creatinine rose to 5 milligram after 1 year. He was advised AV fistula. As soon as any surgery is told, patients run away, and he was not to be found for 8 months. Then one day he appeared, one night rather. He turned up from a weight of 45 kilos. His original weight was 65 kilos in pulmonary edema with the creatinine of 6.5. So that was an indication of dialysis. We put in a neckline, dialyzed. His serum albumin was 2.8 gram, and he died after 2 dialysis. So what has happened? He has lost his weight. The serum creatinine is lower value compared because of his weight, because he doesn't have muscle mass. Even though the GFR is very low, serum creatinine is not that high. It should be, suppose he is 65 kilos, it should have been 10 milligram, 11 milligram. Patient could have opted for a fistula in time. That would have saved him a lot of problem. You could have come for a follow-up. So what is the lesson we learn in this? Timely fistula creation is critical. We advise fistula around 5 milligram. When the patient has got 5 milligram of creatinine, we advise fistula. It is a lifeline of CKD patients. Fistula making is very important. We should preserve the veins at least on one hand, so that they are able to have a fistula on time. Even if patients are planned for CAPD or on CAPD, we should create fistula. I have seen a very leading orthopedician's wife losing her life because of CAPD peritonitis. She didn't have a fistula, they put a neckline, landed in problem. A good AV fistula is the main factor for the longevity of the patient and success in our own dialysis program. We have very good fistulas. So we hardly have any patients on other modes of therapy like permacath, and hardly 1%, 2% we have permacath and all that. And where permacath is the other one used, where longevity is all used commonly in US and other places, longevity is less. Grafts are very costly, more expertise required, more expenses, and less longevity. So the fistula is the best mode of dialysis. So create it in time, do not wait. Just because patient is unwilling, you have to force him, try to force, cajole him. Otherwise, he will be landing up in a messy situation where neckline you have to put at bittite or something. And we always vaccinate the patients against hepatitis and check the anti-HBs titer and ensure the anti-HBs titer is more than 100. The last 15 years, not a single patient or staff has developed hepatitis B in our unit, and all our staff are also vaccinated. So, it is important because these patients are going to be exposed to blood products, are going to be on dialysis, where new patients will be coming and going. So, there is always a risk they can develop hepatitis B. So, the incidence in India has come down very much. Hepatitis B nowadays I am seeing new patients relatively much less compared to 10-15 years back, and none of our patients have developed. And what about the protein restriction? Protein restriction is valid for the patient with renal failure only if the patient has a BMI of 22 at least. That means they are an optimal BMI and they have a serum albumin of more than 4 grams. Otherwise, protein restriction I am telling you will lead to death. The single factor determining mortality in dialysis patients is hypoalbuminuria. The lower, even 1 gram, 0.1 gram, there is a difference. The gradient is definitely there. From 3.8 to 3.6, the patient longevity comes down. 3.6 to 3.4, it comes down. So, most important factor is the good albumin levels. Low albumin and low BMI, meaning calorie as well as hypoproteinemia, is a disaster. And as far as possible, give the first quality protein. There is a tendency to restrict protein because it will increase the creatinine. All right, even if it increases, you can dialyze and remove, but you are not improving the kidney function. Original cause of restriction of protein is to reduce the load on the glomerulus, but if protein malnutrition or calorie malnutrition is going to be the problem, what you are trying to achieve will be more than offset by the malnutrition. So, no point in restricting proteins because most of our patients, even normal individuals, are not protein overloaded. They have the protein intake itself is much less. So, you have to make sure they receive adequate protein and as far as possible first quality protein. The question I am often asked in many meetings is when to start dialysis. It is a very individualized decision. We decide based on the patient to patient. Any chronic kidney disease who is symptomatic due to renal failure, generally a creatinine of over 8 milligram, a poor appetite, patient's appetite beyond a point will not improve unless you get dialyzed. Patients who have gained too much weight due to edema, these patients are more prone for pulmonary edema, more prone for dyspnea, their life becomes miserable, they are unable to move or walk much. So, too much edema, you are not able to get rid of edema with diuretics or side effects of diuretics, definitely that is an indication. Too much weight loss due to calorie or protein, they become more and more malnourished. That means they are not taking adequate food because the appetite is lost because of uremia. Such patients also, if they start losing weight, dry weight, they become below the ideal body weight, that means these patients are at risk of malnutrition and at risk of death. So, you have to start them. Then cardiac indications will be poor ejection fraction, diastolic dysfunction, pericardial effusion beyond a point. Uncontrolled, some patients have uncontrolled hyperkalemia, whatever drugs you give, it's not controlled, that is an indication. I have a patient on dialysis for 3 years, just pick for hyperkalemia alone, unable to control, and she has got a GFR of about 20, still totally unable, and she comes and has the dialysis only for that. And poor lung reserve, those who had a past pulmonary tuberculosis or smokers, they have poor lung reserve, they can't tolerate a pulmonary edema, they will collapse. So, such patients, you have an occupational hazard, a brick kiln owner who has, because of this we started him on dialysis. Of course, now he has reached end stage. So, poor lung reserve also would be an indication for dialysis. So, also the lessons learnt is creatinine is low because body mass is low and does not necessarily reflect GFR. Adequate calories and mild prostration if and only if the serum albumin is normal. Timely dialysis postponement is not advisable. It should be timed. Is it worthwhile doing it very early? Abroad they tried it very early, start 3 milligram, 4 milligram creatinine. No, that again increases the mortality. The time they live will be less. So, you have to time it well. You should not be too early, nor it should be too late. So, postponing dialysis is really a dangerous thing. Dialysis improves the appetite, liberalizes liquid and salt intake, and definitely well-being. Initially they accept they have to come for dialysis. After that, they become, it's quite all right. Many of them, even those patients who refuse dialysis initially, they realize the benefit, the quality of life changes, they are able to eat better, and dialysis is not undertaken just like that. We undertake only if required. So definitely subject the patient to dialysis only when and only when required. So we will see another case patient. This patient was detected diabetic at 35 years. He was taking treatment with sulphonylureas, hemoglobin A1C was between 7 and 9. He started developing edema at 43 years, 24-hour protein of 3 grams, creatinine was 1 milligram, he was put on amlodipine diuretic, BP was 160/100, and he ended up at dialysis at 45 years. So what are the observations? Point is, we should have been treated with metformin beginning itself, because metformin is the only oral drug which will reduce the HbA1c by 2. The HbA1c target of 7 may not be appropriate for a young person, provided he does not get hypoglycemia. Target is not 7, it should be as low as possible, 6.5, 6 also it should be acceptable. Try to get as much control as possible. Because of the legacy effect, where you control sugar earlier, the long-term complications come down. The first few years of control are very important. So first few years do not neglect, control them well. Early diabetic control is important to prevent future even if the control goes haywire little later, this legacy effect continues. And he should have been regularly checked for microproteinuria, because he has been having 10 years, 8 years, and you should have used AC inhibitors, ARB for BP control, and BP target should have been 130/80, not 160/100. 160/100 looks innocuous, but for a diabetic it is high. We have to target. So this is the BP target for patients who are diabetic, patients other than diabetics who have more than 1 gram proteinuria, and patients who already have CKD. The target BP should be 130/80. Other conditions 140/90 is all right. So diabetic patients, patients who have proteinuria due to any disease, glomerular disease or anything, more than 1 gram, and patients who already have a CKD, something like creatinine 2 milligram, 2.5, 1.6, all those patients, the BP target is different, it is 130/80. So as a surrogate marker, we check the systemic blood pressure and keep it at 130 or 80. Is it useful to reduce further 120/70? No, it is proved it is not useful. So don't try to go very much below that. For an average built individual, of course, some individuals who are lean body mass, this may not be appropriate. For an ordinary individual, the target should be 130/80. So what is the diagnostic definition of microalbuminuria, macroalbuminuria, normoalbuminuria? You remember, microalbuminuria is where the 24-hour urinary albumin excretion is 30 to 300 milligram per day, or 30 to 300 milligram per gram of creatinine. This is called microalbuminuria. Below that, it is called normoalbuminuria, below 30, and more than 300 becomes macroalbuminuria. So microalbuminuria is 30 to 300 milligram per day, or 30 to 300 milligram per gram of creatinine. This is at a spot urine specimen. This will be microalbuminuria. Why we are so much talk about microalbuminuria? Because it is an early reversible marker of kidney disease. So it is also an early marker of cardiac disease. Those who are microalbuminuria positive are more likely to get cardiac disease. So that is why the annual screening is advocated, and it signifies endothelial dysfunction, not necessarily kidney alone, it general endothelial dysfunction, and also it means this is the stage where it is reversible. So this indicates reversible renal involvement, where you try to be more aggressive, tell the patient to have better glycemic control, better BP control, try to control him. That is why the microalbuminuria so much talk about it. So diabetic kidney disease, so does the glycemic control have an impact? Yes, definitely. Recommended target is HbA1c and lower, less than 7 and lower still for younger patients. 1% fall in HbA1c was associated with a 37% reduction in microvascular endpoint, not so much for macrovascular, but definitely for microvascular like renal. So definitely the control of sugar, blood sugars are important. So what are the factors which will retard the progression of renal function, renal failure? One is the control of hypertension, 130/80, hemoglobin A1C 7 or even less, LDL cholesterol less than 100 or even 70, triglyceride less than 200, BMI between 20 to 25, avoidance of smoking and avoidance of NSAID. This 7 steps would definitely prevent the stroke, ischemic heart disease and also the peripheral vascular disease. So, this is another patient of mine, actually a classmate of mine, a schoolmate. He was a professor and he had a diabetic nephropathy and ischemic heart disease. He was working in Chandigarh. So, he became very sick, there was no fever, nothing, and he was detected to have a creatinine of 9 milligram. He was dialyzed and airlifted to Chennai. So, he was admitted in a hospital, there was no precipitating cause. So, they told him that you have to undergo a CABG and transplant quite many years back. So, then he came to me and we pursued the old records. When he pursued the old records, we found that he had only proteinuria and creatinine was never beyond 2 milligram. So, we suspected acute on chronic kidney disease. Checked the pre-dialysis creatinine. We found it was around 6, gave him 1 or 2 dialysis, then we found it was coming down. Whenever we check the pre-dialysis creatinine, that indicates the somewhat the native kidney function. That is why we check it before, just before the next dialysis or when dialysis is due. Supposing we want to withdraw a patient, we check it on the day of dialysis when the dialysis is planned. If it is very low, we discontinue the dialysis and wait. We watch his potassium and all that, wait and the other things. So, we withdrew him from dialysis, gradually improved, creatinine settled around 2.5 milligram and we still, I do not know the cause for the worsening of renal function. So, acute renal failure is more common in diabetics. Of all the acute renal failures which we see, which is not due to infectious disease like leptospira, malaria or cholera, other things like drugs and all that is more common with diabetic patients, especially those who already have proteinuria, early stage of diabetic nephropathy. So, we should always suspect acute renal failure when the patient becomes sick suddenly or the patient has a fever, any associated jaundice, purpura, petechiae. However, the urinary sediment is benign except in the case of pyelonephritis where you would find lot of pus cell scars. Similarly, patient has anuria that suggests it is an obstruction and the kidney size will be normal. So, these are the clinical clues to acute renal failure in diabetics. Of course, in diabetics generally the kidney size will be normal even in end stage. That is why in other patients you can differentiate by ultrasound alone, but in diabetics you can't differentiate acute or chronic renal failure based on the kidney size. So, acute renal failure versus chronic kidney disease in diabetics. Diabetic kidney disease often have normal sized kidneys and proteinuria would suggest a CKD, but not necessarily. Even proteinuric individuals are more likely to develop acute renal failure, easier to develop. So, unless you demonstrate a gradual rise of creatinine over months and years which is equivalent to CKD, just because you find one value of CKD very high, 9 milligram or 8 milligram, do not think it is not reversible. And the patient had sudden fever, very sick patient, ICU patient, very drugs are there, you will find ARF. I see ARF very commonly in diabetics. So, assume if you are not sure, think it is ARF. You always write in the diagnosis it is acute and chronic renal failure. So that otherwise sometimes you find patients will go on for dialysis if you do not check their creatinine and all that regularly. This is another patient of mine who was a 59-year-old very high official in the railways. He was a diabetic of 20 years on hemodialysis, very malnourished individuals. Once he developed pulmonary edema, was ventilated in a railway hospital, found to have triple vessel disease. They did a CABG and all his relatives are all diabetic. So, his wife's brother gave the kidney, brother-in-law. Now he is quite fine, 7 years or 8 years now. He is now 67 or something, 68. He climbs 5 floors to the railway hospital or railway office which you see in Southern Railway. He claims he does not go by lift because he wants to work and lectures, gives lectures to various on administrative and probably what not to do in railways to all the management groups. So, one thing is you see the cardiovascular events. Chronic kidney disease predicts CVD much more, this is normally, and even more in diabetics. If you see the cardiovascular events in the population, you see if the patients are having more GFR, the incidents are less. As the GFR comes down, the cardiovascular events goes more and more. This is more in case of diabetics. So, definitely transplant is a better option for diabetics compared to dialysis. So, it is estimated diabetic transplant patients live twice longer with transplant compared to, considering all other factors, forgetting or including considering after all the factors like other morbidities, weight, size of the patient, size of the kidney, everything after confounding factors are removed, transplant patients on diabetic patients live twice longer compared to hemodialysis. We have done more than 400, 500 diabetic transplant alone, not the regular transplant, diabetic transplant. And definitely we find we are not nowadays worried to do diabetic transplant. I have not had an occasion in the last 10 years to turn away a diabetic patient who is less than 60 or 65, 60, 62 away from, towards transplant unless they don't have a donor. And definitely you've seen cardiac function improves, even 28% become 58 or something. Definitely even without CAB. Number of times we do the pre-transplant workup and do a coronary angiogram, we find they don't have any problem. But such patients will have very poor ejection fraction. Definitely after doing the renal transplant, the cardiac function improves and it comes to near normal. So diabetic ESRD is not a contraindication for transplant. On the other hand, it is an indication for transplant subject to the availability of donor. Definitely these patients should be transplanted if possible. If you have cardiovascular disease, definitely we do the angioplasty or we do a CABG and then take them for transplant. We have also done CABG after transplant, after 5 years, 8 years, 2 years we have done CABG and plasty for those patients, they are all doing well. So should not be too much worried whether because they have poor ejection fraction cardiac disease, you must always be very aggressive, otherwise you lose them. If you put them on dialysis alone, after a year or two somewhere something goes wrong and you lose them. So there is another patient of mine who was a diabetic, he had fever and dysuria. Not a mine actually, he was from suffered by somebody. He has not had his sugar checked for some time. So took Rosin, lot of water, thinking that will be alright, dysuria will be alright. He landed at midnight when she became very sick. Couldn't manage, and we found he had severe loin tenderness and sugar was uncontrolled, diagnosed of acute pyelonephritis. This is another common problem we face nowadays. So here the features of pyelonephritis, in contrast to the cystitis alone, is the fever, flank pain and dysuria. From unknown reason, all the nephrologists are finding lot of increased incidence of pyelonephritis. Pyelonephritis used to be a rarity in 20 years back. Now it has become very, very common. We see even patients who are non-diabetic, 16-year-old female I have seen, and this patient had abdominal pain. These are the features: abdominal pain, vomiting, renal angle tenderness, pus cells in the urine. Pus cell casts, they are found. These are rarely found, but commonly you find number of pus cells. And elderly patients will have subtle symptoms. They may not have full blown manifestations. And bacteremia is quite common. In pyelonephritis, you may think that you may not isolate from the blood because number of times it is the same organism found in the gastrointestinal tract, namely the E. coli and all that. Even then, bacteremia is common in pyelonephritis also. So this is the CT patient. You see these are translucent areas compared to the kidney, which is enlarged compared to the other kidney, and you find the translucent areas suggesting some active infection there. So acute, how to treat acute pyelonephritis is a complicated UTI. Complicated UTI is UTI which is not simple, which is maybe an immunocompromised individual or some other abnormality or something like that. You must always take a blood culture and urine culture, because nowadays you beat back tech, we can get the blood culture within 24 hours, or when even sensitivity we get the growth is positive. I have had recently a patient within 2 hours of keeping in back tech, they got the culture became positive. And within 24 hours we got the sensitivity, we corrected according to the sensitivity. Take a urine culture, plate immediately, don't delay, immediately plate, and do the sugar, urea, creatinine, chest X-ray, ultrasound. And if you are not sure, consider plain CT. No, don't put a contrast, because unlike you were told earlier that pyelonephritis does not cause renal failure, not at all true. Pyelonephritis causes renal failure, and so do a plain CT, assess the hydration. The patients may be sick, they will be dehydrated, they won't have taken their food, give a saline, and if assess if they are very sick. If they look okay, you can consider treating with levofloxacin or Septron alone. Even now it's possible the patient doesn't look sick. The patient turns sick, definitely admit the patient. Next day itself we must ask the patient to come, because it is it can go very rapid, especially in a diabetic who has got, if the patient is well controlled diabetic, then think of levofloxacin or something. If the patient is not well controlled, it is an indication for admission. Condition can worsen very rapidly, within a day or so it can worsen. Consider definitely the parenteral antibiotics in such patients. So what we treat according to the local sensitive antibiotics we treat. Nowadays earlier we were using Ceftazidime, now we use a lot of cefoperazone sulbactam, 1.5 gram BD or 3 gram BD, depending on the patient weight and the sickness, or piperazine tazobactam, 4.5 gram, 8th hourly, not BD, 8th hourly. Because the piperazine tazobactam may slightly cover the Pseudomonas better. So, if the hospital acquired or something, you would consider, or transplant patient, you would consider piperazine tazobactam. And look for other evidence of infection. You have any other evidence of infection, catheters, necklines and all that, which would suggest a staphylococcal bacteremia. So, you have to cover the staph if the patient is sick with vancomycin or teicoplanin, and always watch for renal failure. The choice of antibiotic will depend on the locally sensitive antibiotics. So, depending on that you can modify for the gram negative carotid, but remember staph in patients who are susceptible, those with necklines, catheters and all that. So, recurrent UTI, culture and treat as per sensitivity, treat for a longer period, and the acute pyelonephritis also we must treat for a longer period. Injectable may be unpalatable, but the sensitivity comes only for injectable, you have to treat them for 14 days. For recurrent UTI, consider prophylaxis. You use a Septron 1 tablet, I use Septron very commonly, or levofloxacin I use very commonly. Some patients also can use postcoital prophylaxis. When to test further, you have, supposing a patient is sick, febrile, you have to rule out an abscess. In just such conditions, you test further. What are the tests you have to do? Do fasting, postprandial sugar, HbA1c, ultrasound with full bladder, post-void urine, repeat the urine culture and rule out blockade. In young individuals, do Euroflow. This is not necessarily diabetics, any patient. Do PR for older males and PV for females. You have to rule reflex has to be ruled out, stone has to be ruled out, obstruction has to be ruled out. Many of these are done with the ultrasound. So, ultrasound will be the most ideal and repeatable and repeat it as required. Investigation for the urinary tract infection. Do you require CT and MRI? Yes, whenever needed. When ultrasound is normal, suspect acute pyelonephritis, CT is more sensitive, consider plain CT. Any obstruction you suspect, obstruction can be both stone obstruction or a soft tissue obstruction. We can see often we come across papillary necrosis more than stone nowadays. We come across papillary necrosis obstructing. So, ultrasound will say no stone, there is a mass obstructing. So, any obstruction with renal failure we consider MR urogram. We do MR urogram with plain CT cut because stone is not seen in the MR. So, stone will be seen, but to detect the papilla which is obstructing the ureter, definitely MR urogram with plain CT will show that, because it will be an indication for stenting and also aggressive antibiotic therapy. So, next we will see another diabetic patient who was with hypotension. A 60-year-old diabetic was living alone. He was admitted with obtundation. Creatinine came as 4 milligram and dosy. He came in the midnight. So, the doctor wanted to start on dialysis because our everywhere in 24 hours we dialyze. We do not worry at all. So, the indication the duty doctor himself will put the catheter and start dialysis. So, duty doctor said he is drowsy sir, creatinine has come to 4 milligram, other reports were not available, I will start him on dialysis because I am suspecting uremic encephalopathy. So, clinically he was dehydrated and sodium was 115 only, potassium was low. On the drug history taking he was had a poor intake, had some fever and he worsened and he was on thiazide diuretics. So, here is a clear cut case of diuretic induced hyponatremia. This nowadays we are finding more because of volume contraction, you have ADH release and decreased free water excretion is there. So, the patients become hyponatremic. In addition, hypocalcemia also occurs, which does not occur with other causes of hyponatremia. Most of the time potassium will be normal in hyponatremia. This is one condition where potassium is low, that is an indication that it is most probably diuretic, which can cause hyponatremia as well as hypocalcemia. So, which is the diuretic which causes more hyponatremia? Commonly we would think the loop diuretics are more powerful. So, like Lasix or furosemide or other drugs, you would think they are the ones which will cause more hyponatremia, but not so. Actually, the ones which cause more are thiazides because they do not impair the urinary concentration. So, the concentration is relatively preserved. So, the water is somewhat more absorbed, only the sodium is excreted. And incidentally, you remember that loop diuretics are also used for the correction of hyponatremia. We will see later how. So, thiazides, patients on thiazide, because nowadays an explosion of patients on thiazides. So definitely it is becoming more. So one has to be careful, especially in the elderly population who don't drink much of water and all that. The hyponatremias do occur. So these are all the various options to treat any hyponatremia. Any hyponatremia, what you have to do is, these are the only options. One is you can restrict fluids, give normal salt. That is one option. Second is give saline. Saline is 152, 154 milliequivalents per liter, slightly hypertonic to the plasma. Other option is to give hypertonic saline, 3% saline. The third option is to give, another option to give hypertonic saline along with furosemide, so that you excrete more of free water. So ultimately the sodium gets corrected, you are able to get the free water out because of furosemide. That is why I said furosemide does not cause much of hyponatremia, thiazide costs more. Other one is what we can do is V2 receptor antagonist, now which has become available. So you will be tempted, any hyponatremia, why not give easy, instead of giving all these things, fluids, monitoring, output, sodium, all those things, forget, and give tolvaptan. That will correct the hyponatremia. That will be the various options you would think. In this patient, the sodium was 115. What we used normal saline is 154. That means this itself gives is enough to correct, and patient is volume depleted. So it is a case of hyponatremia with volume depletion. Such patients, saline is enough. You don't have to resort to all the exotic methods like tolvaptan and all that. Use saline, add KCl orally, ask them to liberally take the KCl, and control the sugar, and patient improved and creatinine came down to as low as 2 milligram. So nowadays we find lot of hyponatremias, increased hyponatremias. One thing, because labs are also very tuned. Previously we used to get hyponatremia, we'll think is lab has given a wrong method. Nowadays no, because nowadays they use a very sensitive. Earlier they were using a flame photometer. Nowadays they use ion selective electrodes. Any big lab or any good lab, as a matter of fact, because it is not very costly. It costs hardly 1.5 lakhs for the instrument, and recurrent cost also is relatively cheap, less. So we do not think of pseudo hyponatremia and all nowadays. We think it is true hyponatremia, and you have to treat, otherwise you lose the patient. At the same time, you have to be careful whenever you use the 3% saline, because when you use the 3% saline, or as a matter of fact correction of hyponatremia, if you correct more than 10 milliequivalents in a day or more than 18 milliequivalents in a day, the patients are more likely to develop CNS problems. They can develop CPM or central pontine myelinosis. I have seen patients treated outside. I see at least one a year nowadays, I would think, one a year who has been aggressively treated very aggressively and land up with problem. And CT is, MRI shows, and it is difficult if the lesions are advanced, very difficult to make the patient survive. But number of times lesions are not so advanced and we are able to pull out the patient. So CPM is the actual entity which we are seeing more and more nowadays. So do not correct very aggressively, do not correct more than 10 milliequivalents per day, first day, and 18 milliequivalents for 2 days. Don't give hypertonic straight away. If at all you can calculate the extracellular fluid distribution of sodium and then correct it accordingly. So saline alone is enough because it is 154 milliequivalents and patients is only 115. That itself is enough to correct the hyponatremia. Then the last patient I will think of is a diabetic with a patient with hypercalcemia. I will make it very short. This patient came to us very drowsy, dehydrated, 56-year-old diabetic. He was admitted in emergency. The creatinine was 6.8 and the calcium was found to be 16.5 milligram. So we dialyzed him, the calcium came down and creatinine also came down because the worsening of creatinine has happened because of hypercalcemia. So the creatinine came down to as low as 1.4 milligram. So what has happened is it's an acute renal failure which has been caused by hypercalcemia. So when we took the history, it was revealed that patient was on Rocaltrol, that is 125-dihydroxycholecalciferol, Rocaltrol. So the patient was found to have normal renal function, despite that he was being given Rocaltrol because he had a osteoporosis. So because he has sustained a fracture, he was given Rocaltrol to counter and make sure the patient has the thing. What has happened is that has caused hypercalcemia, it has worsened the renal function. Once the renal function worsens, the calcium, more and more calcium is retained and patient went into hypercalcemia with acute renal failure. Nowadays, the maximum number of hypercalcemia, what I see is all iatrogenic. Earlier it was because primary hyperparathyroidism is relatively low. And we also treat with active vitamin D very often. So if you take, you can close your eyes and say any hypercalcemia, I would not think of malignancy as given in the books. I would not think of primary hyperthyroidism, which I see hardly 1 or 2 or 3 a year maximum. That's all we see. At the 2, I detect means it's even less, maybe 1 or 2. So definitely, I would think it is. I can close my eyes and say all other hypercalcemia we are seeing practically are all due to iatrogenic. This is because of the drugs which we give. So you have to be very careful with the use of vitamin D. Do not use active vitamin D. Active vitamin D, I mean the 125 dihydroxycholesterol or 1-alpha calcidol. These are the ones, the alpha-dol and other one is localtrol. These are the ones. So normal renal function patients do not require this. This can precipitate hypercalcemia like anything. Also, if you use nowadays, vitamin D is available for 60,000 units. So it is a very high dose. It is all right for an ordinary person. Without checking the 25-hydroxy levels, unless they are less than 20 or less than 30, you should not use this because this can push them to toxicity. It is enough. It is not. We do not worry about the toxicity of vitamin D, but the hypercalcemia it causes in those with mild renal failure or those with proteinuria individuals, such of those it can cause fair amount. This dose is not available in UK. I don't know about the other countries. This dose capsule is not available because one of my friends requested me to set this 60,000 because he said it's not available in UK because it's sort of banned. It's not, they don't give more than 1,000 units per day. So the vitamin D requirements for individuals is only about 1,000 units per day. If it is the 25-hydroxy level can be considered, if it is less than 30, you can think it is somewhat insufficient. Less than 20, you think definitely low levels. More than 100, it can be definitely toxic due to vitamin D toxic. So you have to be very careful with the use of very high dose of vitamin D and also avoid the use of vitamin D, active vitamin D in normal individuals. And I have seen a single kidney of a judge's wife got admitted midnight. A patient who came there, she said, urine stopped, that's all. I don't know, sir, I was normal, nothing happened. I was gone to a Trichy or somewhere and urine stopped. So doctor said, you go to, when they were near Madras, he said, you straight away go to Dr. Vijayakumar, he will take care of you. And next day morning I saw her, at midnight she got admitted. We found she had only one kidney. The stone was there, we removed the stone immediately rather than go for, by the time she had renal failure, 4.5 milligram or so. We straight away did the stone removal, basketed out, and she recovered fully. On history, she was taking ordinary calcium supplement with active vitamin D. So 1 tablet, 0.25 only for a long time because of osteoporosis. So be very careful with the use of drugs unless you have a reliable lab, because number of labs, the measurement of calcium is difficult. They may miss. They may give normal calcium as high or high calcium as normal. So whenever the lab technician is ignorant, what he does is he gives normal value. He feels it's safe. So you be very careful, and I am sure with the increasing use of vitamin D, this is going to be a major problem for all patients. So to sum up, we know that diabetes is a major cause of ESD, SRD, and there are various manifestations or what I have seen in the last few years. Some of them I have put before you. So we have to prevent diabetes. I don't know. You have to consider drugs for preventing diabetes. Maybe use some metformin, carbo, something, and try to detect early. Early detection is going to be most important because early you detect, better chance patient gets controlled better. So you should do the population screening with blood sugars or HbA1c. It's open to question. Definitely, probably it will come because once you have the point of care instruments for HbA1c.